So, shall we start, ma'am?
Sure, sure.
So, I request the attention of all the faculties and delegates. I will take few minutes of yours and let me introduce me and the faculty members of the session. So, good evening and welcome to one and all. This is Ankita from Clirnet, the assigned session assistant for a seamless experience. And Clirnet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. Clirnet is very proud to be a digital partner for this event organized by Oncology Integrated Society. And topic of today's session is Cancer Cervix Update. Let's begin today's session, for which I would like to invite Dr. Dept Chaturvedi ma'am to take over. She is a gold medalist of Obscini GRMC Gwalior. She is also the present member of executive body GOGS GKP. So without any further delay, ma'am, please proceed with
Yeah.
your talk. Over to you, ma'am.
Okay. Hi and welcome all to this first episode of 2024 Oncology Integrated Society webinar. For this, it's a proud privilege and matter of honor to host this webinar on the burning topic, cervical cancer awareness and update. The first part will give you about the screening and update, and the next part will give you about the management part. In this, we are having very recognized people to shower their blessings and give you the deliberations. Like we have the NIGF President, Honourable Dr. Sadhna Gupta, to give us the pearls of wisdom. And we have Dr. Rupinder Sekhon, who is the President of AGOI, to deliver her speech and talk on the update us on cervical cancer screening. You must have heard a lot, but to the latest 90-70-90 slogan, she'll be detailing it in a proper way and giving you a lot to learn more about HPV vaccination. And then we have Ma'am Reena Srivastav, who is the ex-HOD and who has been a great person of her times and has organized various events that will be detailed later. And Dr. Chaturvedi, who is a proud owner of Chaturvedi Cancer Hospital and who has been past president UPARI and who is now received many awards, who has taken special training at Manchester and UK, Exeter and Holland, and who has been in practice for oncology over past 40 years, and who is the president of our Oncology Integrated Society. But first, I would call all of you for the lighting of lamp, all the dignitaries and the participants for the lighting of lamp. Yes. Now, first I'll call Dr. Sadhna Gupta, who is the president, NIGF, for giving a few words of her blessings and pearls of wisdom. But first, I would like to, no doubt, I have to tell at least the main points about her introduction, because everyone knows about her, but many don't know completely about her. And she's a very good human being, a very forgiving person, and she's full of love and laughter. She has been past chairperson Foxy Safe Motherhood Committee, and she had received Foxy Meru Dara Han Sotia Award for the best committee activity. She represented 3 times India to the WHO on key women issues like quality RCH, essential postnatal and newborn care, Millennium Developmental Goals. She received Dr. APJ Abdul Kalam Lifetime Achievement Award by the DGF 23 last year only. She received 3 times Corion Award winner for Best Scientific Research Paper 2002, 2004 and 2009. She is an awardee 3 times of the Foxy D.C. Datta Prize for her best Foxy publication and bandwidth. She is the key organizer. She has been the key organizer of many national and international conferences, and over Gorakhpur also she has been all the time organizing something or the other. As she has received she has been awarded 7 oration national and international forums. She has been awarded for her oration. But she has special interest in high risk and operative obstetrics and advanced fertility, fetal medicine, and reproductive endocrinology. She is the director and senior consultant OBGY of her Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. Ma'am, please give us your wise words.
Thank you, Dr. Deepti, this loving invite. And my regards to all senior person and all people who have joined this very important program. My regards to Dr. Reena Srivastav, who has been always a source of light and the wisdom to all, and always she is there with us. Dr. Sunil Choudary, Dr. A.K. Chaturvedi, and of course Dept and Dr. Rupinder Sekhon, which has been the opportunity to meet her recently in Lucknow, and she is a real like a very knowledgeable and experienced person in oncology, and we really look forward to listen to her always, and we look always have been the AGOI and the society has been really blessed to have her as a president of a Association of Gynec Oncology. So once again, thank you and Happy New Year to all who are there.
Yeah.
And I can see Tagu Chaya as well, who is my junior, and now she's NIGF state coordinator for the Rajasthan chapter. So my greetings to everybody who is there today. And it is the January month is for the awareness for the cervical cancer. And I congratulate Dr. Deepti that she has organized this webinar with very eminent speakers, and we all are going to be benefited from it. Prevention of cancer cervix is one of the very, very important aim and the national health priority for our country. When India is set for the third largest economy and India dreams to become a developed country in next 10 years, the elimination of cervical cancer will be one of the very important thing which a developed country want to achieve, because all developed countries have actually eliminated in all practical sense cervical cancer from their country. And the key management, key issues, key steps were the first, it was organized screening, it was mandatory screening right from the age of 30 to 45, followed by the vaccine, HPV vaccine. Now, India, we have a 1.3 billion people have, and the both things have got their own issues, be it a HPV vaccination to all adolescent girl or all eligible women, on the organized screening for all women. However, HPV vaccine will be something, it is a like a leapfrogging for us, because if we implement the maximum vaccination, few states have achieved around Punjab and Northeast states have achieved around 90% vaccination, and we are going to see the result in after 10 to 15 years. We cannot eliminate organized screening respective of presence of the vaccination, and that onus goes to all OB-GYN and their leadership. We need to have the leadership like Dr. Rupinder, Dr. Reena, Dr. Deepti. Dr. Reena has been the always working very hard at present. She is a North Zone coordinator for this HPV vaccination drive in our country. So this is very important that somehow in our institution, actually we have to be very practical. In our institution, we have to promote with the banners, with the good protocol screening, with the good backup if the cytology is wrong, if its cytology is doubtful, what to do. So this is the onus, because what we say, developed country is not a something we achieve and we it is a everybody's effort. And what we always share that no, not everybody is a oncologist like Dr. Rupinder or Dr. A.K. Chaturvedi, but we all are preventive oncologists, and we do our like contribution in promoting HPV vaccination, reaching to adolescent girls, reaching to like a maximum number of screening, that is 90% vaccination, 70% screening at least. And then comes the third thing, that the 90% achieve the good care if it is a cancer cervix. So a lot of things we can do together. And I again once congratulate Dr. Dept Chaturvedi for organizing a webinar in this particular month by the eminent speaker. And we all looking forward to listen to our eminent speaker and the pulse of wisdom from the chairs. Thank you, Dipti, for the introduction.
Thank you, Dr. Sadhana, for such a wide and such an integrated answer to whatever questions we had in mind, and many things which we didn't think of really. And it is a nice combination of screening and treatment. Like awareness consists of screening, and treatment, of course, we are doing always. Thank you so much, Dr. Sadhana. And now I'll invite Dr. A.K. Chaturvedi to give a small introduction to the topic.
Thank you, Dr. Deepti. As you know, cancer cervix is a preventable cancer. And this is very important. Why it is important? Globally, it is fourth most common cancer, which amounts to roughly 604,000 cancer patients every year, in which out of which 34,200 mortalities are seen over the world. But in India, it is the second most common cancer. And every year, 132,000 new cases are detected in India, out of which 74,000 deaths per year are noted. That means over 200 women are lost because of the cervical cancer every day in India. That is nearly 8 women per hour, or we can say 1 woman dies after 8 minutes. So this is very serious offense, serious problem in India, and this is a preventable cancer. And why it is occurring, as you all know, is the early marriages, multiparity. This can be prevented. Poor socioeconomic status, HPV virus infection. HPV 16 and 18 is supposed to be responsible for 70% of cases for carcinoma cervix. So this is found highest in the low socioeconomic status patients. So we have to improve the socioeconomic status and personal hygiene. Plus, we have to attack on the HPV virus, which will be which will be dealt with in the next lecture. And cervical cancer usually takes 10 to 15 years to develop from the initial stage. Once the dysplasia is detected in early stage, it takes nearly 10 to 15 years to develop in full-fledged cancer. So here the role comes from the gynec side, that whenever you see the dysplasia, you have to put the patient on follow-up and keep on seeing the things, do all the investigation, and you have to act accordingly. So to discuss on these issues, I am inviting Dr. Professor Reena Srivastav as a chairperson. She is ex-professor and head of department, BRD Medical College, Gorakhpur. She was past president UP chapter of Obstetrics and Gynae, past president Gorakhpur Menopause Society, fellow ICOG, North Zone Coordinator SS and PP, past treasurer, secretary, and president Gorakhpur Ops and Gynae Society. She has organized UPCOG in 2003 and 2016 at Gorakhpur. She has organized NY Foxy at Gorakhpur, organized CEFOG 19 at Gorakhpur, organized numerous CME workshop at BRD Medical College, and she was actively involved in teaching regarding cancer patients, cancer. And she organized she is author chapter in many books, many papers published in national and international journals. Felicitated by Dainik Jagran for outstanding work for humanity. She was also felicitated by Amar Ujala for outstanding work for humanity. She is a very good person. Now I invite Dr. Reena Srivastava to conduct the further proceedings. Dr. Reena Srivastava.
Thank you, Dr. Chaturvedi, for so nice, lovely words. And now we would be starting the session with the first speaker, whom I am going to introduce to you. She is Dr. Rupinder Sekhon, Chair, Gynae Oncology at Artemis Cancer Center, Artemis Hospitals, Delhi, NCR. She is at present President AOGI in India. She is President AGOI, that is Association of Gynae Oncology of India. Program Director, DNRB, Gynecology Oncology. She is Program Director, AGOI Fellowship. She is a certified robotic console surgeon. She is a diploma in advanced laparoscopy and hysteroscopy from Germany and fellowship from Gynae Oncology from Kidwai Memorial Institute of Oncology. Formerly, she was Senior Consultant and Chief Gynae Oncology at Rajiv Gandhi Cancer Hospital. Then she is Classified Specialist OBGYN Gynae in Army Medical Corps, Member Ethics Committee for Cervical Cancer in NICPR, published more than 65 articles in national and international journals. She has been awarded Chief of Air Staff Commendation 26 January 98 and Best Gynae Oncologist Delhi by Times Research Media 2012 and 23. And she pioneered first to perform robotic surgery for gynae oncology, then first to do HIPEC, first to do HITOC, first to do PIPEC for palliation of ovarian cancers. So with these laurels to her credit, Dr. Rupinder is with us to talk on screening of cancer cervix as well as vaccination. I invite Dr. Rupinder Sekhon for this deliberation.
Good evening, everyone. And thank you so much, Dr. Reena, for this kind introduction. So my slides are not opening, so I would request the admin to post the slides. I'll take it from there.
Ankita, please post her slides.
Ankita, do you have a slides?
Yeah, I've sent the slides to her.
Yes, ma'am. This one, right, ma'am?
Yeah, that's right.
Make it big.
Yeah, that's fine. Everyone can see, please?
Just a minute, ma'am.
Yes, we can see, Dr. Rupinder.
Please instruct me, ma'am, when to go to the next slide. It takes time for it.
Okay, fine. Next. So as you know, that few diseases that reflect global inequities as much as cervical cancer. And cervical cancer is the fourth most common form of cancer amongst women worldwide. More than 85% of those affected are young, undereducated women, communities. And furthermore, 90% of deaths, they occur in low and middle income countries. The disease kills more than 3 lakh people, women every year, and annually it is diagnosed in over 6 lakh women. Next, please. So it is otherwise the fourth most frequent cancer in women, with an estimated 5,70,000 new cases in 2018, representing 6.6% of all female cancers. And to reiterate again, 90% of the deaths from cervical cancer, they occur in low and middle income countries. When we come to India, next slide, please. Next slide, please. The Indian statistics say that about 1,23,907 cases are diagnosed every year, and the mortality is 77,348 cases. In short, 1 woman dies of cervical cancer every 8 minutes in India. Next slide. So what is the pathogenesis of this deadly disease? Next slide. So this is just to show you that we all know that the endocervix is lined by columnar cells and the ectocervix is lined by squamous cells. It is these columnar cells which undergo transformation into squamous cells. And at this junction, at the squamocolumnar junction, is where we have all the trouble. That is why when we take pap smears or when we look for examination, when we want to do colposcopy, when we want to do anything at all to do with the cervix and actually diagnose the lesion on the cervix, we have to actually look at the squamocolumnar junction. And this is where the cells change, and this is where all the morphology goes haywire, if at all. Next slide, please. Now, having said this, I want everyone to understand that cervical cancer is basically a sexually transmitted disease. We do not want to say this, but it really is a sexually transmitted disease. And for it to actually happen, HPV is the main cause. That is, HPV is the main factor. HPV does not cause the cancer, right? You need so many other cofactors, but the presence of HPV is most important for causing cervical cancer. That means we do have some non-HPV cancers also, but almost 90% of the cervical cancer is HPV related. Next slide, please. So what is this HPV? This is a human papilloma virus. Now, there are about 100 types of human papilloma viruses, but we are not studying all of them. We are only studying some of them which are oncogenic. Oncogenic are those which cause cancer. Now, as far as the cervix is concerned, the main oncogenic viruses are HPV-16 and HPV-18. And the non-oncogenic viruses that we study are 6 and 11. Apart from 16 and 18, where 16 is mostly responsible for causing squamous cell carcinoma, and 18 is mostly responsible for causing adenocarcinoma. They are also responsible for causing vaginal and vulvar cancers. And if along with this, we add 31, 33, 45, 52, and 58, which are the other high-risk HPV viruses that we say like that, then we are covering almost 90% of cervical cancer. Next slide, please. So to reiterate, it is the persistent infection with high-risk HPV which causes cervical cancer. And this gets transmitted by sexual as well as non-sexual routes. Just a tribute to Dr. Harald Zarusen, whom we lost last year. He received the Nobel Prize in Medicine in 2008 for isolating oncogenic HPV strains and elucidating the oncogenic process. Next slide, please. So now, having said all this, let us see what is the natural history of cervical cancer. So you have the normal cervix, you have the HPV-related changes, you have the LSIL, that is the low-grade squamous intraepithelial lesion, or atypia, which is the same as CIN1. Then you have the high-grade squamous cell intraepithelial lesion, which is the same as CIN2 and 3, and also includes CIS, that is, and after that, invasive cancer. Next slide. Next, please. So we see that HPV infection, in 70% of the times, it clears within 1 year. And in 2 years, 90% of the infection clears. So about 60% regress within 2 to 3 years. So all these HPV-related changes, within 2 to 3 years, 60% of them will regress. Next, please. About 15%, they persist. And they progress within 3 to 4 years. And 30 to 70% progress within 10 years. So something was what Dr. A.K. Chaturvedi said earlier on, we see that progress to invasive cancer may take as much as 10 years and even more. Next, please. Next. And next. And next. So how does it develop? You have wherever HPV persists, and then you have other cofactors like immunosuppression, smoking, multiple partners, all those high-risk factors, several children, early menopause, early sexual debut, all of these combined along with HPV, they are the ones who will ultimately result in invasive cancer. Next slide, please. So just to show you, next slide, please. Yeah, so you see there is a very clear demarcation. There is between how does the cervix look? Here, I would request everyone that whenever a patient comes to you, please put in a Cusco speculum and have a look at the cervix. By and by, just by merely looking at the cervix, you would be able to gauge that this is healthy and this is unhealthy. And even if it is unhealthy, this is perhaps just infection, and this perhaps is precancer or maybe even invasive cancer. So you can see that most of all these images, they look quite like each other, except if you look at them closely, then you realize the differentiation between the transient infection and the HPV viral persistence. Next slide. So what are the determinants of HPV infection? For women, young age, peak age is around 20 to 24 years. That is the HPV infection. Lifetime number of sexual partners, early age of first sexual intercourse, smoking, oral contraceptive use, genital tract infections, and the immunocompromised states. For men, young age, again, peak age is 25 to 29 years. Again, several sexual partners, uncircumscribed males, and sexual partner with the CIN. So if the female has CIN, she can, which is HPV related, she can also give it to her male partner, and vice versa. Not only that you blame the men, you can blame the women as well. If at all, you can call it blame. Next slide. Next slide, please. We see that how it evolves from a normal infection, and you can have LSIL, then LSIL, it can clear off most of the times. By 93% of HPV infection is cleared by 3 years. But if it persists, then you will find that from low-grade lesion, you can have a high-grade lesion. And from the high-grade lesion, it can progress to carcinoma. And this latency period can be as much as 15 years. And it is because we have this latency period is we can address the cervix at this point in time. And this enables us to completely prevent cervical cancer, the invasive cervical cancer. Next slide. So when we see the natural history of the disease, you need to see this slide very closely. We see that around 15, 16 years, that is where our youngsters, it is more in the Western world, but now even in our country, they have their sexual debut. They get infected with HPV. Now, like I said, for 93%, it clears off in 3 years or something like that, right? So by the time they are 30 years, most of them would have cleared their HPV infection. After 30 years, for those who still have the HPV infection, those are the ones that you need to address. And that is where you need to do the HPV testing, along with maybe finding out, is there a lesion on the cervix or not? Right? So this is basically the natural history. So this very nicely explains that when to vaccinate, when to screen, when to look for the disease, and how frequently to screen, and so on and so forth. I will just address all that just now. Next slide, please. So we see that cervical cancer isn't just treatable, it is preventable, and it can be screened as well. So taking this into consideration, next slide, please. On 19th May 2018, the WHO Director General, Dr. Tedros Adhanom, made a global call for action towards elimination of cervical cancer. So they said that we can eliminate, the WHO put forward a statement saying we can eliminate cervical cancer as a public health problem through intensified vaccination against HPV, screening, and treatment. So please, next slide, please. Yeah, so this is a picture which most of us have seen splashed everywhere where there is a call to eliminate the cervical cancer. Next slide. So what do you mean by eliminate? See, it cannot go away completely. Let us be practical. But when we are talking of elimination, we are talking of looking at a target wherein there are less than 4 cases per 100,000 women years. Presently, this figure is around 12 cases per 100,000 women years. So if we can achieve this target of less than 4 cases, then we are already looking towards complete elimination of cervical cancer by the year 2030. And how are we going to eliminate this? By vaccinating 90% of our girls. 70% of the women who are at the age 35 years and above, they should be screened. And 90% of women who are identified with cervical disease of any kind, invasive or non-invasive, they will receive expert treatment and care. So what are the preventive strategies? Next slide, please. Next slide, please. Yeah, so now we have spoken about prevention. Now, what are the preventive strategies? So you can have primary prevention, secondary prevention, and tertiary prevention. You will see that in this slide also, there is this graph which shows you what is the peak of HPV infection and how it slowly, completely goes off by itself by the time the patient is 30 years old, or she's hardly a patient actually, by the time the woman is 30 years old. So primary prevention entails girls 9 to 15 years old. Here, it also includes boys. It means that you are going to give them adequate health information and warnings about tobacco use, sexual education, condom promotion, and male circumcision. What is secondary prevention? That is for women more than 30 years. That means screening and treatment is needed. So you will do either screen and treat with low-cost technology or HPV testing for high-risk HPV types. And tertiary prevention is treatment of invasive cancer at any age, no matter what it is, like whatever you may do. You might do ablative surgery or radiotherapy or chemoradiation or whatever else. Next slide, please. So addressing the primary prevention first. So we understand that for primary prevention, most important is the HPV vaccine, which was actually bivalent, quadrivalent, and nonavalent, as we all know. Bivalent being 16 and 18, quadrivalent being addressing 6, 11, 16, and 18, and nonavalent addressing all these 4, plus the other high-risk HPVs, that is 31, 33, 45, 52, and 58. And now what do we have in addition? We have bivalent Cervix, which, please, next slide, please. Next slide. Next slide. Yes. So now what do we have? The Cervix, we all know, is no longer available. They have stopped manufacturing the vaccine, and it is no longer available. Quadrivalent is available only in our country and in some other countries like us. It is no longer available in US. In US, only the non-valent Gardasil is available. And quadrivalent Cervavac, manufactured by the Serum Institute of India, is licensed for girls as well as boys in our country. They are saying that the cost of this is going to be around 400 rupees, but that will be only when it is part of the government program. As of now, Cervic is available over the counter at any chemist shop. For 4,000 rupees, you get 2 doses. Next slide, please. Next slide, please. So to go over the dosage schedule. No. Previous slide, please. It'll have the dosing. Yes, yeah, that one. Thank you. So you have the optimal dose and you have the reduced dose. Now, what is the optimal dose? Optimal dose is 2 doses between 9 to 14 years, at least 6 months apart. That means less than 15 years. That you can give 2 doses to the girl child, but both the doses should be at least 6 months apart. 3 doses above 15 years. From 15 to 26 years, 3 doses at 0, 1, and 2 months. Right? And 3 doses for older women till 45 years of age. Regular screening as per guidelines has to be followed in this age group. Now, this is the optimal dose schedule with a level 1 evidence and grade A recommendation. What is the reduced dose? Now, 2 doses, WHO and SAGE, they have recommended 1 or 2 doses for 9 to 14 years, 1 or 2 doses for 15 to 20 years, and 2 doses for 21 years and above. Single dose schedule can be used for girls and boys aged 9 to 20 years. So this is what has now come up, that even a single dose of vaccination is about as effective as giving 3 dose schedules. For boys, they can be vaccinated from 9 to 26 years, 9 to 14 years, 2 dose schedule, 15 to 26 years, 3 dose schedules. However, all these reduced dose schedules of HPV vaccination, they await the DCGI approval in India. So as of now, they are just off-label recommendations. Next slide, please. Next slide. So now we've got the dose schedules. What is the next thing? Next thing is, who should we give these? Who are the primary targets and who are the secondary targets. Now, WHO recommended primary target population for HPV vaccination in girls aged 9 to 14 years before they become sexually active. And achieving over 80% coverage in girls also reduces the risk of HPV infection in boys, right? So there is what is known as herd immunity. And vaccination of secondary target population. What is the secondary target population? That is females aged more than 15 years, boys, older males, or men who have sex with men. This is recommended only if this is feasible and affordable, and does not divert resources from the vaccination of the primary target population. So this is the population where even WHO recommends, in other words, that possibly you have to buy the vaccine yourself, but the primary target group should definitely be covered by the government in their immunization schedules. Next slide, please. Storage of, next slide, storage. Yeah. Storage of HPV vaccines. All HPV vaccines are stored at 2 to 8 degrees centigrade, not frozen, but protected from light. They should be administered immediately after removal from the refrigerator. Dosage schedule I have already gone over. It is a 0.5 ml dose, and it is to be given in the deltoid, not in the hip, please. And make your patient sit on a chair and let her be sitting there, or at least in your clinic, for at least 5 minutes after you have administered the vaccine. There are no serious safety issues till date have been recorded. Mild systemic adverse events might be there, some nausea, vomiting, and all, which you can have with any vaccine whatsoever. They are safe and they are well tolerated. Next slide, please. Co-administration. Next slide, please. Yes. Now, can you give this HPV vaccine with other vaccinations? Yes, you can. You can definitely do that. And efforts should be made to administer the same vaccine for all doses when using a multi-dose schedule. So it's not that one time you're giving Gardasil, then you're giving Cervix, or you're giving Cervivec. No. Please try and use the same type of vaccine for the whole dose schedule. However, if you are really pushed to the wall and for whatever reason that is not available, you can interchange. That is what they say. What are the special situations? The HPV vaccination is definitely not recommended for use in pregnancy. However, lactating women can use it. Sexual assault survivors should be given age-appropriate HPV vaccination with the first dose at the time of initial examination. Women with abnormal PAP, positive HPV test, previous HPV lesion, etc., they can also be vaccinated, but you have to explain to them that it is only limited efficacious for them, and that they are not completely protected, and that to undergo screening nevertheless. To reiterate, HPV vaccination is a primary prevention intervention and does not eliminate the need for screening, since the existing vaccines do not protect against all high-risk HPV. The screening of the cervical cancer should be done as per guidelines. Let us not forget this. Next slide, please. Next slide. Now, how am I saying all this, about the reduced doses, that you can give only 2 doses or 1 dose or 3 doses or whatever? So a very nice study was done where the immunogenicity and HPV infection after 1, 2, and 3 doses of quadrivalent HPV vaccine in girls in India was tested. Fine. And next slide. Next slide. Yes, so this is a busy slide. I'll just go on to next. So here they found that the incidence and persistent HPV 16, 18, 6 and 11 infections is similar in both 2-dose as well as the 3-dose regime. So that means they are saying both are equally effective, whether you give 2 doses or you give 3 doses. But like I said before, that it has yet to receive DCGI approval. And if you do it, you will have to counsel the patient, and it is an off-label indication. Next slide. So now this was about 2 doses. Now, what about a single dose? Now you all remember that in Andhra Pradesh there was all that hula bula about about 6 girls losing their lives. Somebody had jumped into the well, somebody committed suicide or whatever else, or somebody had high fever and encephalitis. And the newspapers, they wrote a lot about HPV vaccination. So what actually happened was that as a result of all this, and so it was stopped. The vaccination was stopped. So what happened? Some girls received 1 dose only, some received 2 doses, and some received 3 doses. That we got this collateral benefit of being able to study the immunogenicity in all these 3 types of dosage scheduling. So whether 3 doses have been received or 2 or 1. And in this paper, which was published by our own people, it was found that a single dose of HPV vaccine provides similar protection against persistent infection from HPV 16 and 18, the genotypes responsible for nearly 70% of cervical cancer, to that provided by 2 or 3 doses, right? So if we are looking for protection against HPV 16 and 18, even a single dose is perhaps just as effective. Next slide. So what does the World Health, next slide please. Yeah. So what does the World Health Organization have to say about it? SAGE recommends updating dose schedules for HPV as follows: 1 or 2 dose schedule for primary target of girls aged 9 to 14, 1 or 2 dose schedule for young women aged 15 to 20, and 2 doses with a 6-month interval for women older than 21. Next slide, please. So other very important factor comes boys. Should we vaccinate our boys? So I'm sure you also get people in your clinic who are saying that, yes, we are ready to vaccinate our girls, but what about the boys? You're calling it a sexually transmitted disease, cervical cancer. Then why are we not protecting our boys? So HPV vaccination of boys alongside girls would facilitate the eradication of HPV and protect boys from infection, reduce transmission, increase herd immunity, and effectively prevent HPV-associated diseases. Limiting HPV vaccination to girls will not lead to eradication. Understand? Because there has to be a herd immunity. So if you give this vaccination only to girls, you are not going to be able to achieve your eradication target very easily. So that is why definitely it is also recommended that we should vaccinate the boys as well. So all of this was primary prevention. Now let us get on to secondary prevention. Next slide, please. Next slide, please. Yeah, so secondary prevention is essentially screening. Next slide, please. So what is there? Next slide, please. So what is there in cervical cancer screening? Next slide, please. Yes. So what are our screening options? How can we screen? Either by cytology or by molecular markers or by visual inspection. So cytology would mean actually basically your pap smear and LBC and all that. Molecular would mean your nucleic acid amplification test, DNA methylation and protein markers. And visual inspection, we all know that is the wire. That is what screen. Now, how are you going to screen your patient? Next slide, please. So before I go on to explaining how we are going to screen, I just want to impress upon this very important paper that WHO recommends that HPV self-sampling should be made available as an additional approach to sampling in cervical cancer screening services for women aged 30 to 60 years. So this is a very important step which we hope to take in our country as well, and which would be able to cover at least 75% of our female population who should undergo screening. Because nobody wants to go to a doctor, nobody wants to go and expose themselves, lie down there. I'm perfectly fine. What are you trying to do? But if we introduce the self-sampling, then of course we would be able to screen so many more. What does it mean? The individual collecting one's own vaginal sample. Methods include a single-use swab or cervical brush. Self-sample HPV tests could provide similar accuracy to clinician sample tests. Sensitivity is 60 to 90%. Specificity is 88%. Limitations, of course, it is user dependent. She may not do, she might not, actually insert in the vagina. She might do something else, so on. And then transportation might be a problem. All those kind of things. Next slide, please. Other methods via, that is visual inspection with acetic acid. Everyone is familiar with this. We have to use 3 to 5% of diluted acetic acid and look out for the acetovite areas. Everything which goes white is not really an acetovite area. The acetovite area should be very well demarcated. It should be on the transformation zone and not on the endocervix, because that has columnar cells and that will show white. Okay, so your acetovite area has to be on the squamocolumnar junction, and margins should be very well demarcated. And it should be a very specific lesion. It should not be that the whole of it has become white. No, that is metaplasia. That is infection. And it is because of infection that the whole thing has become white. No, that is not acetovite. That is not via. You can further complement it by using Lugol's iodine. That is villi, that, right? Next slide, please. Accuracy of screening tests. Cytology is about 91 to 99% specificity, but we have to remember this is only when it is done by a trained pathologist in trained settings. Otherwise, even in the best of hands, cytology is only, the sensitivity is only 50%. HPV testing, of course, it's maximum 94% sensitivity and 88% specificity. Next slide, please. So what are the screening guidelines for cervical cancer, if I may say? Next slide, please. You start at 21 years as per the USPSTF. As per WHO, you start at 30 years, and by all these American associations, that is ACS, ASCCP, and ASCCP, by 25 years. You stop screening at 65 years. According to USPSTF, according to WHO, you can stop the screening at 50 years, and according to ACS, at 65 years. For 21 to 29 years, PAP every 3 yearly. For 30 years, cytology every 3 years, or high-risk HPV testing every 5 years, or co-testing every 5 years. WHO recommends HPV DNA 5 years to 10 years. High-risk HPV testing every 5 years, or co-testing every 5 years as per the American guidelines. Then age to end screening, 65 years with adequate negative prior screening. I mean, if the patient is having positive screening, and just because she's 65, you don't end it there. You are going to stop screening at 65 only if she has had previous 2 or 3 negative screening reports. And 50 years if resources are available. 50 to 65 years can be screened if patient has never been screened ever before in lifetime. And according to American guidelines, 65 years with adequate negative prior screening. So you see all the guidelines as to when we should start screening, when we should stop screening, when we should continue screening, what should be the interval for screening. They all vary as per various associations and guidelines. Whereas WHO suggests starting regular, next slide, please. Yeah. Whereas WHO suggests starting regular cervical screening at the age of 25 years amongst women living with HIV. Screening interval of every 3 to 5 years when using HPV DNA detection, and 3 yearly if using cytology. Stop screening at 50 years of age after 2 consecutive negative screening results consistent with recommended regular screening intervals. Next slide, please. Next slide, please. So what are our recommendations? What does FOGSI recommend? No, please. Yes, go to the previous slide. So as per FOGSI recommendations, age to start screening should be 25 years in good resource setting, and universal recommendation at 30 years. Age to end screening, 65 years with 3 consecutive negative cytology results, or 2 consecutive negative HPV tests within 10 years. The most recent test should have been performed within 5 years. Tests with screening interval, primary HPV, high-risk HPV testing every 5 to 10 years, in limited resource setting at least twice in a lifetime. Cytology every 3 years, and via every 3 to 5 years. Screening after hysterectomy with removal of the cervix is not recommended. Screening for immunocompromised women start much earlier, that is at 25 years. So for patients who have been hysterectomized, you have to first know what is the indication for hysterectomy. If the indication for hysterectomy is a fibroid uterus or an AUB or some such thing, then you do not necessarily have to do a more frequent screening. However, if the hysterectomy, for whatever reason, is for, say, a carcinoma in situ or for CIN3, then of course you have to do a walt smear and screening much more frequently. Then you follow the oncological screening patterns, which is every 3 months for 2 years and every 6 months for the next 3 years. So that is the pattern you have to follow. Right. Next slide, please. So algorithm is just the same depending on whatever resource settings you have. If you have good resource settings, obviously you would do an HPV DNA. Whereas if you have low resource settings, then of course you can do via. So that is the long spectrum. On one side, we have via, and on the other side, you have HPV DNA. And depending upon what is your resource setting, what is your availability, what are the type of patients you are seeing, what is the kind of clinic you're working in, there is a whole wide spectrum that you can actually do screening for patients. Now, how do we manage these screening lesions? Next, please. Next. Next. Okay, so there are two approaches. Either screen and treat approach, that is, the decision to treat is based on a positive primary screening test only. You have seen a positive via their self, you do a cryocautery because you think this patient is not going to come back to you. Number one. Number two, you might not get an opportunity to see her again. With great difficulty, you have persuaded her that you need to do screening. So these are the patients. Or if you are doing a camp somewhere in a remote area and there are a whole lot of ladies that you are examining, then this is the area where you should use the screen and treat approach. Otherwise, there is screen, triage, and treat approach. The decision to treat is based on a positive primary screening test followed by a positive second test. Okay, a VIA is positive and you have done colposcopy. After that, taken a biopsy, and depending on the report of the biopsy, you treat. Or you have done an HPV and the HPV high risk test has come positive. You have done a colposcopy and taken a colposcopic directed biopsy, and depending upon what that biopsy the report is, you treat her or you don't treat her, or you put her on observation. So that is screen, triage, and treat approach. So this is next slide, please. Yeah, next. Yes. So next, just keep tapping you. So cytology, colposcopy, and treat. Next. Yeah. So either high risk HPV DNA, and then you do the genotyping and then treat. Just what I have said before, right? Same thing. Next slide, please. Next slide. Yeah. Next slide. Isn't it moving? Yeah. Next slide. Just yes. So this is just to remind all of us that let us not get confused with the reports which we get, if it is a low LSIL or if it is a CIN. So LSIL and CIN1 are actually what used to be mild dysplasia. And HSIL, what is it? HSIL is what used to be CIN2 and CIN3. Now, LSIL and HSIL are reports which we will get on cytology. Whereas CIN1, CIN2, CIN3, you need a biopsy, right? Previous terminology used to be mild dysplasia, moderate dysplasia, severe dysplasia, carcinoma in situ. I mean, all these are basically depend completely on the pathologist. One pathologist might call it CIN1, another one might call it CIN3. I always tell them that a CIN2 is always a pathologist grading, because one might say it is severe dysplasia, another one might say it is low-grade dysplasia. So unless it is clear out and out LSIL or HSIL, be very, very guarded in your management. Next slide, please. Next slide, please. So to reiterate all that we have spoken till now, if there is subclinical HPV infection, in 90% of the times there is spontaneous regression. If there is low-grade SIL or CIN1, 50% of the times there is spontaneous regression. If there is high-grade squamous intraepithelial lesion, still there is regression in about 30% of the cases, and only in the rest might progress to an invasive cancer. So we just have to remember this, and we don't have to panic, and we have to make sure that your patient also does not panic if she gets a LSIL or a HSIL report. Next, please. How it is to be treated? I'm talking to a very august gathering. Everybody knows you can either do a LEAP or a laser excision. Hysterectomy should be done only if you are back to the wall. Patient is coming with repeated infections, they're not clearing up, and your high risk HPV is positive or whatever else, and there is some other lesion, some large fibroids and all that is there, then perhaps you might want to do a hysterectomy. Otherwise, just a LEAP or a cold knife conization is more than enough. Next slide, please. Selection of treatment modality. Again, I am not addressing the colposcopy. I'm not giving a talk on colposcopy, but only I'm just telling you that it depends upon the type of transformation zone, on the age parity and fertility aspirations, then on your clinical skill, your availability of resources, and so on and so forth, and whether the patient is likely to default or not. Next slide, please. So much for your vaccination. I've spoken on the vaccination. I've spoken on the pre-invasive lesions. I've spoken on the management of pre-invasive lesions. Just 2 slides on the management of invasive cancer. Next slide, please. So this basically comes under the head of tertiary prevention. So vaccination was primary prevention, screening was secondary prevention, and treatment of invasive cancer is tertiary prevention. Next slide, please. So next slide, please. Next slide, please. So as per the new FIGO staging, we now have a 1B3 stage also, where the lesion is more than 4 centimeters and the para might be soft, and such patients, you can address them surgically if you have the expertise. Another thing which has been addressed in the new FIGO staging is that the nodes have been addressed. So you have a 3C1 and a 3C2. So if you have positive pelvic nodes, it becomes 3C1. And if you have positive para-aortic nodes, 3C2. And how are you going to gauge these nodes? Next slide, please. It is by imaging. Next slide, please. Yes, it is by imaging. So imaging has now been allowed for staging cervical cancer. Previously we used to talk about staging cervical cancer only clinically, but now imaging too has been added. So that is why you have that if enlarged. So if the pelvic node is enlarged or the para-aortic node is enlarged, you can easily stage them in 3C1 and 3C2. Next slide, please. So treatment options, they're all there. Stage 1A, no LVSI, cone biopsy, negative margins, extrafacial hysterectomy. Stage 1A1 with LVSI and stage 1A2, again, modified radical hysterectomy. Next slide, please. So 1B1, B2, 2A1, all that depends upon your expertise. Also 1B3, it all depends on how expert you are at doing a proper RH type 3. So if you think that you might not be able to do all of that and you might not be able to do a complete lymph node clearance, we have to remember that there is no berry picking involved in that. You have to do a complete nodal clearance of the pelvis. So if you have the expertise, please go ahead. But if you think you would rather not, then CTRT is just as well. Next slide, please. So for 1B3, 2A2 and all that, either you give pelvic EBRT. I'm not addressing the details of treatment. I'm just touching upon it. And of course, stage 4B systemic therapy and plus minus individualized RT and all that. Next slide, please. Next slide. So this is just one of our specimens of radical hysterectomy. You can see a very, very wide parameter has been taken. And there's a very long margin, at least a 2.5 centimeter vaginal margin has been taken. Now, all of this is very important. Next slide, please. Just a word about fertility sparing. So if it is stage 1A1 and there is no LVSI, LVSI is very important. If there is no lymphovascular space invasion, you can, even for a stage 1A1 cancer, you can do a cone biopsy. Or if the patient does have LVSI, you can do a radical trachelectomy, which can be done both vaginally as well as abdominally. Anything more than 1B1, you should not do trachelectomy. Some people do it for a stage 1B2 also. That means where the growth is about 2 to 4 centimeters, but it is suggested that no, we should not take those kind of chances. Next slide, please. So that is just a specimen to show you, just a diagrammatic representation to show you what abdominal trachelectomy actually means. So we are going to take a cuff of vagina and all the paravaginal tissues as well. See, and you can just clamp just at the level of the uterines. So you can clamp the uterines as well. It doesn't matter. It's okay. The uterus will remain fine. And then stitch the uterine wall to the vagina. So that is what abdominal trachelectomy is all about. Next slide, please. Yes, so see how nicely that pictorial diagram shows you that the uterus, the amputated uterus, one would say, is stitched to the vagina. There you can see one of our cases, that is what we had done for one of our cases, that is a true picture. Next slide, please. Yeah, there you can see when you look at it abdominally, there, that is how it is. Next slide, please. So that is all that in short I have explained about cervical cancer, and I hope you understood most of it. Thank you so much for the opportunity. Thank you so much, Dr. Chaturvedi. And it was nice to see Dr. Sadhana Gupta and everybody else. Thanks a lot. Have a good evening.
Thank you, Dr. Rupinder, for such a nice deliberation, very point-wise primary, secondary, tertiary prevention, and about the vaccination and screening to be done. Basically, people need to know that vaccination is now a must for all the girls and boys before 15 years. And what WHO says that first you target the girls, and because once we are going to take whole lot of boys and girls collectively, there might be this thing less of the vaccines available in India. So they say that first and if your resources permit, then girls. And when taking this vaccination program, there are so many questions from the attendants. Why do my girl needs it? Is she not? Is she not? Is she not having a good character? And all those points are to be there. They have to be once right in time, that is 9 to 1, and we need to give it before any sexual contact, any close contact, even before the penetrative sex. So it is a must before 14 years, number one. And the immunity gained at that time is around, say, 90%. If we are going to give it beyond that, that is around 16 to 18, the immunity goes down to 50%. And beyond 18 years, it goes down to 30%. That is a good paper studied by. So that is a must. Before 14 years, we should vaccinate all the boys and girls, number one. And we should explain them that it is not going to take care only of the cervical cancer. It is going to take care of vaginal, vulval, oropharyngeal, and colonic cancers.
Yeah.
Very well taken care of by that vaccine. So like any other vaccine, when it is given in childhood, that is more effective, and that is why we want it to be given before 14 years, because many questions would be there from the patients and we have to answer them. This is very important. I am happy, Dr. Rupinder, you gave all the extract of whatever needed by the practicing OBGYNs. They need to know all this. And while going through this campaign in North India, I found that so many doctors have not vaccinated the children yet.
Yeah,
so after this program, so many doctors even went for vaccinating their children from 9 to 14 years. And it is the important thing is that it is required by clinicians as well. The campaign should go. Hi, Dr. Veena, you are there. Nice to see you.
Yeah.
She's also there. She's from West.
Good evening to all. Good evening to all. Good evening to all. We'll be there 26 for your platinum oration. I'm just listening to Dr. Rupinder. Rupinder, you have covered everything, every aspect. I must congratulate you. And Dr. Veena is with us for the HPV drive, and we have tried to cover as much as the part of our country. And regarding the vaccination, why we are such much bother about, because still we are covering the less than 15% of the HPV vaccination. Although we have the long way of journey, what are the problems which we are facing nowadays? And regarding the screening, you have discussed everything in detail, as Dr. Veena told. Nice discussions about all
very nicely explained, Dr. Rupinder. I think we should go on. And most important point is awareness among the doctors as well as the parents of the children and the girl child and the boys. That is most important.
I would like to add one more thing regarding vaccination. We must find out if there is anybody having head and neck cancer in the family, and the people from the family must be vaccinated. Or see a cervix patient in the family, all the members must be vaccinated. That is important in the case.
Even head and neck cancer, he wants to stress on that.
It has been approved for oropharyngeal cancers also.
Yes. That's why we have to instigate the people, or rather explain them that it is important. Why boys should be vaccinated? This is the reason. If in family you got head and neck cancer, you must try to vaccinate all the females.
That is what I said, Dr. Chaturvedi. We need to talk more about the vaccine.
Yes. Thank you. And very nice deliberation. Thank you. Thank you,
Thanks.
Dr. Reena.
Thank you, Dr.
Thank you so
Rupinder.
much for-
We are
Thank you so
really
much.
obliged to hear
Yes.
it from you, and this was my first time. I'm really, really honored and blessed to have you on this
Thank you.
in our
Thanks.
society.
Thank you, Dr. Rupinder. Very nice
Thank you so
delivery.
much. Thanks for having me. Yeah,
Thank
thanks
you.
a lot.
You are an edge
Now-
above all.
Yeah.
Thanks, ma'am.
Now, this
Thank
is
you.
regarding prevention aspect and how to prevent the public from getting this type of cancer. Now, we are concentrating more on the treatment part. Dr. Sunil Choudary, are you here? Hello, Dr. Sunil?
Yes, sir, I'm here.
Oh, right. Thank you. So our next speaker, Dr. Sunil Choudary, is Professor and Head, Department of Radiotherapy and Radiation Medicine, Institute of Medical Sciences, Banaras, Hindu University, Varanasi. He did his MBBS from Calcutta, MD from SGPGI, then he did SRC from Chandigarh, SCPGI Lucknow, and junior consultant Fortis Hospital, Noida. Then he joined BHU in 2011 as assistant professor. His keen interest was in brachytherapy. He is running classes for that. And he has got many publications, 55 publications, supervised more than 10 MD and PhD students in IMS Research Award 2022. He has got AROI Fellowship at Guy's Hospital, London, severe national and international presentations. AROI Secretary in 2018-20, Ayushman Nodal Officer, BHU, 2020 to 2023, Ayushman Nodal Advisor, 2020 till date. He is still continuing as Ayushman National Advisor. So now I'm inviting Dr. Sunil Choudary. He's a very nice and learned person to speak on management of carcinoma cervix or whatever he wants to speak. His deliberation is welcomed.
Thank you, sir, for your kind words. And it's an honor to be part of this forum. So I really thank you for inviting me for this talk. Just let me start sharing my screen.
Yeah.
So can you see my screen?
The screen is visible, sir, but the PPT hasn't opened yet.
Okay, but I have opened my PPT from my end.
Sometimes it takes time to load, sir.
Okay.
So the PPT is not yet visible, sir. Kindly double tap on that CA cervix.
Okay. Is it now visible? Not yet.
No.
I don't know what to do then. I think, well,
Then you can send it to my WhatsApp and
okay.
I'll send it to her. You can send it.
Should I send it to your WhatsApp number?
You can send on WhatsApp number.
Okay. Give me a moment in that case.
Okay.
Sure. I'll just join the meeting after sharing. Just a moment.
Hello.
Yes, I've sent
Hello,
it.
Ankita. Yes, you can start sharing now.
Yes, ma'am. Ma'am, have you sent it to Ishani?
Yeah, I have sent to you.
To me, ma'am?
Yeah. On your account. You want me to send where?
No, ma'am.
Ritu?
Ma'am, you can send it to, yes, ma'am.
Ritu Safar?
The coordinating person, yes, ma'am.
Ritu Safar, na?
Yes.
Okay,
You can
I'll
send it to
just send.
Ishani also. Ishani
Okay.
also.
Okay, I'll send to.
इनको शुगर है ना? जी। क्या बात है?
ये रमेश चौहान को लास्ट टाइम आपने दवा लिखी थी एंटीबायोटिक।
Just tell her to check. Hello, Ankita.
Yes, ma'am. To whom have you sent, ma'am?
To Ritu.
Okay.
Ask her to check.
Allow me a moment, ma'am. Is my screen visible to everyone?
Let's see.
It's visible. Thank you.
Yeah.
So just instruct me when to go to the next slide. So accordingly, I will go to the next slide.
Yes, Dr. Sunil is there? Or...
Yeah, I'm there.
Yeah, he's there.
Okay. Now you can see, is it visible to you?
Yes, visible to me. Can you hear me? I'm allowed here.
I'm also able to see.
Shall I give you the remote control, sir?
You can. How to go about
just a
it?
minute, sir. So there's a popping up on the screen.
Yes.
Just select that, sir.
The yellow part?
Yeah, to control the screen, there will be an options on the screen.
Option, huh?
Yes.
So what should I choose?
Yes. Yes. No, sir. Just yes. Press confirm.
There's no option of confirmation there.
So what is the
option? You do it, no? As
okay.
Doctor, you just tell her to move next, and then she'll change the slide. You may start now. She'll keep doing it because we are losing time.
Yeah, sure. To begin with, I must congratulate Dr. Rupinder for a very nice talk, and she really briefed about the management of cervical cancer as well. So, since I'm a radiation oncologist, I'll tell much, not in great details, but a brief outline about radiotherapy and surgical part and what to choose and how to choose among the two modalities. So, can you move the slide, please? Yeah. So worldwide, we know that cervical cancer ranks 4th, and in India, it ranks 2nd. With a percentage about 18.3% in India, cervical cancer. Next slide, please. And we know the signs and symptoms. It starts with usually the discharge, which is foul in smell and foul smelling with watery or curdy discharge, and there's a bleeding PV, which may be either contact bleeding or intermenstrual bleeding. And usually when the disease advances, the patient presents with a low backache, and many times the patient complains of painful sexual intercourse as well. Next slide, please. Yeah. The first thing first, we should establish the diagnosis, the thorough clinical examination per vaginum as well as per speculum examination needs to be done. The cervix, the entire cervical fornix, vagina, the vulva, rectal wall, parametrium, along with the inguinal nose and the whole abdomen to see if there's any liver enlargement, as well as the supraclav nose should be examined. And punch biopsy from the periphery of the lesion. Multiple punch biopsy would be recommended so that we don't miss the diagnosis. Next slide, please. This is how the disease spreads. Like starts locally and then spreads to the vagina fornices and the vagina, and it goes into the uterine segment as well. And then it moves anteriorly, it invades the bladder wall, and posteriorly it invades the rectal wall as well. And then this is the direct spread. And then if we talk about the lymphatic spread, it usually goes to the paracervical nodes and then to the internal and external nodes. And from there is the common iliac and the para-aortic. And distant spread is quite, it's not very common in case of CS cervix, but usually if it goes to the lungs. Based on the disease, stage of disease, the chance of involvement in the nodes is there. Like for stage 1 is around 15%, for stage 2 is around 30% pelvic nodes involvement, and for stage 3 is around 40 to 45%. Next slide, please. So based on the pattern spread and the failure of the disease, we need to address the primary disease along with the nose. It can be done by surgery, which is hysterectomy, or radiotherapy. Both of these are local regional treatment. And to take care of the subclinical systemic disease, which is there, so that is taken care by systemic chemotherapy in the form of cisplatin, which is given concurrently with radiotherapy. Can we go to the next slide, please? Yeah. So we need to, before any treatment, we need to have know the general condition of the patient, CBC, LFT, RFT. These will give you the clue, like hemoglobin. If the less, that it should be maintained at 10, at least 10. If the liver functions are deranged, it is a surrogate for liver mets at times. And if the creatinine is raised, then it suggests that the kidney is affected either by hydronephrosis or hydroureteronephrosis. The viral markers need to be done. A chest X-ray will give you a suspicion. If there's any suspicious lesion on chest X-ray, we do a CCT thorax, an ultrasound of the whole abdomen to see any disease in the liver. And the CCT pelvis or the whole abdomen gives you the extent of the disease, which is better appreciated on MRI. MRI gives a better soft tissue picture, and that is the recommended investigation of choice. PET-CT is not well proven, but of course, if one has a facility for PET-CT, it can be done. It gives you functional imaging, and the chances of picking up the nodes in the para-aortic region or somewhere else in the mediastinum or the SCF node is quite high with PET-CT compared to a CCT pelvis or MRI CCT whole abdomen or MRI whole abdomen. Next slide, please. This is the figure staging. Dr. Rupinder had already alluded to this. And based on the figure staging, the treatment is done. So next slide, please. So there are limited treatment options in case of CA cervix. It's either, next slide, please. Yeah, it's mainly surgery or radiotherapy. And if it is radiotherapy, it's combined with chemotherapy. So if it is surgery, then usually the stages where surgery can be done is 1A, 1B1, 1B2, and 2A1. The bulky disease is usually not, if the disease is bulky more than 4 centimeters, surgery is usually not preferred. And if the patient belongs to wants a fertility sparing surgery, then conization, which can be done for 1A1 disease, a simple trachelectomy for 1A1, which is simple pregnancy slightly larger than a conization, and a radical trachelectomy where the cervix along with the paracervical tissue and upper, just the cuff of the vagina is removed. And that can be done for a 1A2 or a 1B1 disease. But these surgeries result in a higher chance of failure, the higher risk of failure with these conservative surgeries. So should be avoided if the patient doesn't want a fertility sparing surgery. The other, the non-fertility sparing surgeries, one is the simple hysterectomy, which is a class 1 hysterectomy, or also called as total hysterectomy, where the uterus with the cervix is removed. So if you see this, the inner line, this connotes a simple hysterectomy, and it can be done for a 1A1 or 1A1 to 1B1 disease with grade 1 to, and it's to where the stromal invasion less than 50%. The other option is a modified radical hysterectomy, which also Wertheim's hysterectomy should be avoided. If you see this line, this connotes, reflects your modified radical hysterectomy, where the part of the little part of the parametrium is spared, and the chance of failure is high with a Wertheim's hysterectomy. So the standard is a radical hysterectomy, mix hysterectomy with a pelvic lymph node dissection. As I said, the chances of disease spreading to the pelvic nodes is quite high. So a pelvic lymph node dissection should be done, or at least a sentinel lymph node biopsy should be done if a facility exists there. Can you move the slide, please? So if surgery is done, there are indications for post-op indications for radiotherapy or chemotherapy. What we follow routinely is the Sedlis criteria in case of post-op cervix. So if any of these two factors are there, are positive, like if on histopath, if we see the tumor is more than 4 centimeter, or if there's a middle or deep stromal invasion, or if the lymphovascular invasion is positive. So any of these two factors, if they are there, then the patient falls into the intermediate risk, and the patient requires post-op RT. If only one factor is there, the patient falls in a low risk category, and radiotherapy can be spared. The other is Peters criteria in case of post-op situation. And if any one of these factors is there, like the patient having a positive lymph node when the pelvic lymph node dissection is done, or if the patient has a R1 resection or a R2 resection, or if the parametrium is positive. So if one of these is positive, the patient will merit radiotherapy along with concurrent chemotherapy, which is usually cisplatin. If the patient has a nephrotoxicity, or if the creatinine clearance is less, in those cases, cisplatin can be replaced with carboplatin. Next slide, please. The other option apart from surgery is radiotherapy. So radiotherapy, it can be alone without any chemotherapy for limited stage disease like 1A to 1B2 disease, where the chances of pelvic lymph node involvement is relatively quite less. For 1A, it's very less than 5%. 1B, 1 and 2 is around 10 to 15%. So in these cases, radiotherapy alone can be offered. Apart, if the patient has 1B3 to 4A disease, these patients will merit external beam radiotherapy with concurrent cisplatin, and this is followed by brachytherapy. or the brachytherapy can be like external beam RT can be sandwiched with brachytherapy based on the stage and the response of EBRT. Patients who have systemic disease, these patients will merit palliative chemotherapy in the form of paclitaxel, cisplatin, or paclitaxel carboplatin. But prognosis for these patients is very dismal, and maybe if the patient has some lesion in the bone or somewhere, a palliative radiotherapy can be offered if the patient is symptomatic for that. Next slide, please. Like the pitfalls and pearls and advantages, pearls and demerits of surgery as well as radiotherapy. If we get into the advantage of surgery, one is that we get accurate nodal involvement assessment with surgery, which is not the case with radiotherapy, upfront radiotherapy. The other advantage is immediate curative therapy. The tumor along with the nose, they're resected out, and that is immediate curative therapy. There's a potential benefit of ovarian conservation in these cases. There's preservation of vaginal function, but sorry, this was a disadvantage which I put it here, wrongly put it here. There's potential need for adjuvant radiotherapy if surgery is done. This is the greatest disadvantage of doing surgery, upfront surgery. The other disadvantages of surgery, one is blood dysfunction and transfusion and anesthesia-related morbidity. The greatest advantage of radiotherapy is avoidance of surgical morbidity. So if we, like many of these patients who undergo surgery will merit radiotherapy. So combining two modalities is always bad. There are literature with conflicting results where even most of these are retrospective, where they have compared surgery alone with surgery followed by radiotherapy, and they haven't seen any increase in toxicity with the combination of surgery with radiotherapy. But that is debatable. The other disadvantages of radiotherapy are, one is a potential loss of ovarian function, the shortening of the vagina and dryness, which results in impaired sexual function. The patient has long-term toxicities in the form of proctitis, bleeding PR, and cystitis. The patient usually comes with hematuria and GI toxicities. But with the improvement in the technology where we practice 3D conformal radiotherapy and IMRT and image-guided radiotherapy, the end results, these late effects are minimized. Next slide, please. So it should be, like if we compare surgery with radiotherapy, we don't get any survival advantage. There's no difference in terms of survival. But adding two modalities will probably give the toxicity of both the modalities. So it's better to choose a single modality. And since we know radiotherapy is non-inferior to surgery, so, and if we do surgery, most of these patients will merit radiotherapy in adjuvant setting. So why not to go with radiotherapy alone and prevent the toxicity of both the modalities? And to put it that there's no role of neoadjuvant or adjuvant chemotherapy. There are many patients who come to us with neoadjuvant chemotherapy. They have already received 3 or 4 or 6 cycles of neoadjuvant, but it's clearly there's no evidence at all that giving neoadjuvant chemotherapy improves survival by any means. So rather, it causes adverse effects and is detrimental to the survival. Like as we increase the duration of treatment, the chance of local control and DFS and OS, they decrease substantially. So it's best to start the primary treatment, that is radiotherapy with concurrent cisplatin, instead of giving neoadjuvant and then subsequently giving radiotherapy. And there's no role of adjuvant chemotherapy at all. Like if we complete radiotherapy with concurrent cisplatin along with brachytherapy, there's no role of adjuvant chemotherapy. Next slide, please. So I briefly tell you about radiotherapy. It's done by external beam radiotherapy. There are two modalities. One is external beam radiotherapy. These are two machines. One is a telecoupled machine, which is usually these are being replaced by linear accelerator in most of the centers. The other is the linear accelerator, where X-ray is used. Here, a radioactive source is used. There's no difference in the survival outcome whether you treat the patient by telecoupled or linear accelerator, but the chances of side effects, the risk of side effects is less with linear accelerator because you can practice IMRT or 3D-CRT with this, whereas with telecoupled, usually practiced by two-dimensional technique. So the toxicity is like higher with telecoupled compared to linear accelerator. The therapeutic ratio is less with telecoupled. Otherwise, in terms of survival, there's no difference because the dose which can be delivered to the target by telecoupled is no different from what can be achieved by linear accelerator. And the other modality is brachytherapy. This is high dose rate brachytherapy after loader. This has an indexer. There are several channels, and these channels are here the iridium or the cobalt source lies inside it. Next slide, please. So these are the steps of radiotherapy. Like first, a simulation is done. The patient is lied down, immobilized, and in a comfortable position because radiotherapy is given over a period of suppose 5 to 6, around 5 weeks, 5.5 weeks. So the patient needs to be comfortable, immobilized, so that the treatment is reproducible. The patient is reproducible. The same region receives the same dose on a daily basis. And after this positioning and the immobilization, the patient is taken for CT scan, and the images in the DICOM format, they're transferred to the treatment planning system, and where the targets are delineated. The target, I mean, to say the cervix, the uterus, and then the nodes which need to be treated. They're segmented, and along with the organ at risk, which are surrounding structures which are surrounding to the targets, like the rectum, the bladder, the bowel, the sigmoid colon, and the femur head. These are the structures which need to be spared when you give radiotherapy. So they need to be delineated. And after the delineation, the planning is done by our medical physicists using several beams. And then we see the DVH, dose volume histogram, where we confirm that the target, the amount of dose we wanted to give to the target has been achieved. And the amount of the constraints we wanted to give to the organ at risk, that's also achieved. Otherwise, if they're not achieved, we ask the medical physicist to replan, to modify the plan. And then after it meets our expectations, the plan is approved. Next slide, please. So based on the disease, if the disease localized to the pelvic region, the uterus, the cervix, then we treat only the pelvis. The entire pelvis is to be treated because we need to address the nodes as well. But in case the nodes are there in the parotic region, then we need to treat the parotic as well along with the pelvic nodes, along with the primary. So this is extended field radiotherapy. So with this extended field radiotherapy, the toxicity is higher to the bowel. So we don't treat the parotic nodes electively. We treat them only when the nodes are positive, significant on radiological investigations. Next slide, please. So I said there's several techniques. One is a 2D planning, which is based on the surface marking on the bony anatomy, usually done on a telecoupled. And then we have, when it's sculptured more, when you contour it more, then it becomes a 3-dimensional when the field, where the radiation beam is given from different directions. And this helps us achieving the dose to the target, and at the same time sparing the normal structures around it. And the final technique is is intensity modulated radiotherapy, where the intensity of the beam is varied within the field. So there is a field within the field when we are doing intensity modulated radiotherapy. So this helps us in, this is the best form of conformal radiotherapy, where the conformity is very high, the sharp dose fall off, and along with the, so the OARs, the organ at risk, they are spared in a better way. And the fourth is image guided, where we see exactly, do the imaging while the patient is being treated, so that the target is not missed. This helps in achieving, helps us in achieving a better, helps us in sparing the organ risk in a better way, because the margins, when we are doing image guided radiotherapy, the volumes, the margins given to the target is less, so the organ at risk are spared in a better way. Next slide, please. These are the different techniques of brachytherapy. This is intracavity brachytherapy, where there's an applicator. It's a set of applicator. There's a intrauterine tandem with a flange, which is inserted into the intrauterine canal. And these are the two AGOIs which are inserted in the furnaces. As you can see, this is in the intrauterine canal, and these are in the furnaces. And then they are fixed together. And this is done when the os is negotiable. This is usually done after the external beam radiotherapy is done, after a dose of 45 to 50 grays given over a period of 5 weeks. Following this application is done usually after a gap of 6 to 7 days. And this is done usually in 3 to 4 sittings or 5 sittings, depending on the dose which is prescribed. But in case the os is not negotiable, where we cannot put the intrauterine tandem, so we don't have a choice but to use this sort of applicator, which is known as MUPIT. And there are many other forms of applicators, pelvic applicators, brachytherapy applicators, where steel needles are inserted into the pelvis, into the growth and structures which need to be treated. So this is interstitial brachytherapy. And the third one, this picture shows you this intravaginal brachytherapy. This is used for patients who have undergone hysterectomy. And since the upper part of the vagina, the vault, is at higher risk of failure, so this region is treated. About 3 to 4 centimeters of the remaining vagina, proximal vagina, is treated with this. So it consists of a tandem with cylinders, multiple cylinders. And these cylinders are of different sizes depending on the diameter, the capacity of the vagina, the different size of cylinders. The largest size of the cylinder is used so that a higher dose can be given to the region. So we have an intercavity applicator. This is interstitial, where the os is not negotiable or the anatomy is poor. There's a gross residual disease, so or the lower part of the vagina is involved, or the more than medial part of the parametrium involved, where the dose cannot be delivered adequately by intracavity. So in those cases, interstitial brachytherapy is to be done to achieve a better local control. Next slide, please. This is after loader for brachytherapy. So after the application is done, so these applicators are connected with a transfer tube, and this transfer tube is connected to this is the indexer, and these have multiple channels, around 24 to 30 channels depending on the machine. And so the source is carried from this after loader through the transfer tube to the applicator and into the tumor. Next slide, please. So as I said, the dose which is given by external beam radiotherapy is around 45 to 50.4 gray. Earlier, we used to give 50 gray in 25 fractions, which resulted in higher GI toxicity. So the ABS recommends a dose of 1.8 gray per fraction. So it's tuned down to 45 gray in 25 fractions, 5 fractions per week. and it's given from Monday to Friday. Along with that, we give cisplatin once a week, every Monday or Tuesday, at a dose of 40 milligram per meter square. And in the patient, if the patient has a poor creatinine clearance less than 40, we replace cisplatin with carboplatin. But replacing cisplatin with carboplatin will give you an inferior result compared to cisplatin. So ideally, it should be cisplatin. It acts as a radiosensitizer and improves the local control. And following this, brachytherapy is done. At times, brachytherapy can be sandwiched with external beam RT, where in the last weeks of external beam RT, where there's a good response, the anatomy is good. And so in these cases, if usually intracavity, this standard application is done, ICRT is done if the os is negotiable and the anatomy is appropriate. Otherwise, interstitial is done. And in case of post-op, as I said, is intravenous using cylinders. And the dose which is given is 5 to 7 gray per fraction. If it is 5 gray per fraction, then it has to be 6 fractions. If it is 7, then 6. If it is 6 gray per fraction, then it has to be 5 fractions. If it is 7 gray per fraction, then it is 4 fractions. So 7 gray into 4, 6 into 5, 5 into 6. And it's usually done once a week, but the recent trend is to give 2 fractions in single application. Like per application, you give 2 fractions, at least 6 hours apart. And then again after a week. But whatever is done, we should see that the treatment gets completed within a period of 8 weeks, ideally 7 weeks, because if the treatment goes beyond 8 weeks, with per day increase in treatment duration, the local control falls by 0.6%. So we should be very careful about it, that the treatment period doesn't spill beyond 8 weeks and ideally 7 weeks. Next slide, please. That was my last slide. Thank you for your kind attention.
Thank you, Dr. Sunil, for your nice presentation. It's really nice to have you. And very nice presentation regarding external beam, intracavity, interstitial insertion of treatment. And I think it's a new thing for the NIGF people, most of the NIGF people. They might have not seen.
Eye-opener to all.
Pardon?
It is an eye-opener to all the doctors.
Yeah.
The variety of treatment of radiotherapy and neoadjuvant and chemo and everything. First part is sin. Second part is without sin. Without sin.
So, if there is any
question,
question, we'll be happy to answer. If there is any query or question.
Any query, please feel
No questions from the delegates.
No question from
Okay. Thank you. All is very clear. And today the talks were so informative and
radiotherapy part is quite boring. So most of the NIGF.
No, he has made it so interesting.
Yeah, but it is. He has made it so interesting that most of the people are staying.
Yeah.
And if you got any query, please ask.
Now, we would like to just now give thanks to all. And we have finished well, much ahead of time, because people were saying 3 hours is too much. We have just finished in 2 hours.
2 hours. Well before time.
Well
so
before
thank you, Dr.
time.
Sunil.
And all
Dr.
those who join late will get disappointed. So now, Dr. Chaturvedi, give your concluding remarks.
So early detection, the role comes from the gynec side. They should educate the people, and we are also there. We are joining hands in conducting certain camps, educational programs, to tell the people that why they should get vaccinated against carcinoma cervix and head and neck cancers. And that is very important because this is responsible for more than 60% of the cancers, HPV virus, head and neck cancer, and cervical cancer. So by educating the people, by vaccinating, we can prevent the public from getting the disease. My advice is to vaccinate male members also of the family, and especially those who are at risk. That means those who are sitting in the family, those person, if they are having anybody who is having head and neck cancer or cervical cancer in the family, they must all vaccinate their kids so that they may not get such type of things in future. Plus, you must improve hygiene, improve health, get good nutrition. These are the few things, and avoid bad habits of chewing tobacco, because that is also responsible in few cases, or rather aggravating the incidence of carcinoma cervix by eating tobacco. So that is also important. So we must educate the public. So thank you very much, Dr. Sunil and Dr. Rupinder. Thank you very much for your nice deliberation. Over to you, Dr. Deepti.
Already written. Thanks, everyone. And again, wishing all a happy new year and 7 festivals in one. Makar Sankranti. I just forgot all that to say in the beginning. So I end it with these few words that remains happy, healthy, and ever shining and illuminated with knowledge all about cancer and prevention and treatment. Thank you all. Thank you all the dignitaries for attending. Thank you, Dr. Sunil Choudary. And kindly please excuse us for a little bit minor.
Not at all, not at all.
Sunil is a nice person, he won't mind. Anyway, but it was a big mistake. We have not paid attention to it.
No, no, no. It's completely all right with me.
Thank you so much. And yours was a real eye-opener, exhaustive, informative, as well as just very nice, to the point, and telling all details about the machines to everyone, all the non-oncologist doctors group, because this is new to everyone. This field is yet to be explored by all. Thank you so much. We'll again keep on calling you for further deliberations.
Sure, thank you.
All right. Thank you so much.
Bye.
Thank you so much, everyone, for the wonderful
Thank you, ma'am.
insights.
Thank you for staying till the last. Dr. Veena Acharya and Ma'am Sekhon. Thank you all. Okay. Thank you, the team, Clirnet. I just forgot. Thank you so much.
All right. So with all the due permissions, we're concluding the session over here. Thank you so much.
Okay. Thank you.